Yes, good evening, dear colleagues. I welcome you to this evening's webinar, How to Tackle Antibiotic Resistance in Urology. My name is Florian Wagenlehner. I'm the head of the Clinic of Urology, Pediatric Urology and Andrology at the Justus Liebig University, Gießen, Germany. Before I start this presentation, I would to give you some housekeeping notes. The presentation will last around 30 minutes, and we will have a question and answer session afterwards for 10 to 15 minutes. Okay, so to start up, these are my conflicts of interest, my general conflicts of interest, but none of these conflicts of interest interfere with today's presentation. Now, the topic of the presentation is antibiotic resistance in general. We know that this is becoming a bigger and bigger problem, and this is a multifactorial problem. And I just will give you some introductory aspects why we nowadays have this problem and not 10 years ago. One of the major reasons is that research in infections and anti-infective research has come down, especially by pharmaceutical companies in the last 20 years. The slides show you that the companies with anti-infective research have declined since 20 to 25 years. Most companies have even abandoned anti-infective research, and which is shown here by this lower image. The blue one is those companies that have entered anti-infective research, and the red ones are those who have exited anti-infective research. And in the recent years, much more companies have exited the anti-infective research field, and very little have entered. Now, therefore, if we summarize that, we have a development deficit of around 15 to 20 years in the research on anti-infective substances especially. And this is problematic because we will have to do that in the near future and always in the future to compete with bacteria, for example, with infectious organisms. Continuously compete, and therefore we need continuous anti-infective research in that area to be able also to compete in the future. Now, what would happen if we do not counteract? There has been a very nice report of Sir O'Neill from the United Kingdom that have not only from a medical or scientific point of view dealt with this problem, but also from an economical point of view. And this O'Neill report, they have looked at this development and gave an outlook if we would not counteract, what would happen in 2050. And this slide shows you how many deaths per year we would have to expect if antimicrobial resistance would increasing and would go on as it is doing now. And in 2050, we will have 10 million or more people dying of antimicrobial resistance pathogens, and that will be more than that will be dying from cancer or other diseases. And not only that we will have an increased morbidity and an increased mortality, we will also have to invest more and more money into infectious diseases. And it has been calculated that by 2050, we will have to invest more than $100 trillion in infectious diseases. And this amount of money will increase by the year 2030 and 2040. Therefore, it would be very wise to invest the money now and not in the end of the middle of this century. Now, to give you some data of our urological patients, there is one surveillance study which is very important in urology. This is the global prevalence study on healthcare-associated infections in urology, the gpiu study, which is undertaken by the European section of infections in urology, a full section of the EAU. And I will draw your attention to this web link, gpiu.acu.org. And this study is taking part every year in November, and you're very welcome to participate and to contribute your own data to this study. And this study has important data, and it is the only study that can contribute data from the urological community. So therefore, the red countries are readily participating in this country, and it is a study where we have data from 12 years now of 56 countries and 27,000 patients that are included in this database. And the results of this study are very well reflected and fed back and are reflected in our guidelines, in our EAU guidelines, and therefore it is important to have as many centers, as many countries, and as many patients being contributed. Now, just some short data from this study. The overall resistance, meaning the total bacterial spectrum of urological patients that have healthcare associated infections, is graphed in this slide. And the first bar of each antibiotic here depicts the overall average resistance. There are also differences from country to country. Asia, for example, has some higher resistance levels as Europe, and within Europe we again have higher resistance levels in Southern Europe compared to North Europe. But nevertheless, also in North Europe, we have dramatically high resistance levels to all antibiotics we readily use in urology, such as fluoroquinolones, cotrimoxazole, beta-lactams, cephalosporins as one of the representatives of the beta-lactams, but also carbapenems, although resistance to carbapenems is still around 10%. Now, this figure is important as it gives us the importance what we should recommend as a guidelines recommendation for empiric treatment to different kinds of infections. And our thresholds for recommendations to severe infections such as urosepsis is around 10%. So we would like to have an antibiotic that has lower levels than 10%. And if we take this overall resistance as a guidance, then you see that only the carbapenems more or less cut this threshold. For more benign infections such as cystitis, for example, lower urinary tract infections, we possibly could accept a higher threshold of 20 to 30%. So this is just a general view. I would like to emphasize that it just can give you a guidance, but for a detailed recommendation, you need your own resistance data from your own department to be able to have a correct and an adaptive primary empiric treatment for your patients. It's not only that the bacteria are resistant to one agent, they are frequently resistant to a variety of unrelated antibiotic substances. And this is expressed by multi-drug resistance. By definition, multi-drug resistance is resistance to more than 3 unrelated antibiotic groups. And again, the results of the gpiu study show you that multi-drug resistance is frequent in urological patients, depending on the different kinds of infections. And if we go, for example, at this different entities of infections in urological patients, then we have male accessory gland infections, such as prostatitis or epididymitis. Then we have asymptomatic bacteriuria, we do have cystitis, we do have pyelonephritis, we do have urosepsis. And if we look at urosepsis, for example, almost half of the patients have bacteria that are multi-drug resistant. And therefore, the more severe the infections are, the higher is the resistance. This might have to do with the increasing age of patients that we see in urology, the increasing multimorbidity, but the higher the severity of the infection, the higher is the multi-drug resistance, which is very important. So coming to the topic of this webinars, tackling antimicrobial resistance, there are more different strategies available. This has been summarized also by the O'Neill report on antimicrobial resistance and is shown here. There are strategies that we can follow from our urological community. There are other strategies such as public awareness, which is a more political strategies. There are strategies which are important for veterinary people, and there are strategies such as vaccines, which are meant for the scientific community to develop those strategies, because for gram-negative organisms, vaccines are currently not available. So certainly one of the strategies is to cut down antimicrobial use, because we know that antimicrobial use increases antimicrobial resistance, and there is several lines of evidence. We know, for example, that areas within hospitals with the highest resistance also have the highest use of antibiotics. We also know that resistance are more prevalent in healthcare-associated infections, so there is a clear association with the healthcare system. We also know that patients with healthcare-associated infections due to resistant pathogens have had received more likely prior antimicrobials. And we know that increasing exposure to antimicrobials increases the likelihood of colonization with the resistant organism. This is primarily important, for example, in transrectal prostate biopsy, where we actively have to ask for prior antibiotic usage, because we know if the patients have had fluoroquinolones or cephalosporins in the prior 6 to 12 months, the colonization in the rectum with the resistant organisms is significantly higher. So the strategies that wraps up this aspect is called antimicrobial stewardship. And the definition of antimicrobial stewardship, that it is a set of coordinated strategies meant to improve the use of antimicrobial medication with the goal to enhance patient health outcomes, to reduce antibiotic resistance, but also to decrease unnecessary costs in our healthcare system. So if we look at the global antibiotic consumption, this is a nice study from Böckel in the Lancet Infectious Diseases, who put together the available data on our global antibiotic consumption worldwide, as shown here in a map. Then we see that the antibiotic consumption is different in the different countries of the world. The darker the countries here in the upper part of this image, the higher is the antibiotic consumption per capita, per person. And you see here there's a large difference between some countries in Europe and, for example, Australia. Australia is among the countries having the highest global consumption, at least in the year 2010. The lower part of this picture, for example, shows the increase or the decrease between the year 2000 and the year 2010. And you see some countries such as North America or Europe have more or less kept their rate or the compound annual consumption, whereas other countries such as Asia, some countries in Africa, countries in Latin America and also Australia have increased their consumption of antibiotics over the last 10 years. This is something that has to be taken in mind and that has to be counteracted. And if we look at the increase of antibiotics over the last 10 years in all our countries, then it's mainly broad-spectrum acting antibiotics, such as broad-spectrum penicillins, broad-spectrum cephalosporins, and broad-spectrum carbapenems. And this is important because the more broad-spectrum than antibiotics act, the higher is the negative effect on our human microbiome. And I just want to draw your attention to us as humans. We are not a single organism, we are a superorganism, like all the biological organisms on our earth. We consist of 10% human cells and 90% microbial bacterial cells. We might be born sterile, but soon after death we acquire the microbiome of our mother, and this changes over our whole life until death. And therefore, each antibiotic which we ingest, which we administer at our patients, has an effect, has a negative effect on the human microbiome, on our microbiome, and this is called collateral damage. There are certain different effects on the different antimicrobial substances or different antibiotic classes. Some antibiotic classes, such as the carbapenems, the cephalosporins, the fluoroquinolones, have a higher negative effect, have a higher collateral damage effect on our microbiome because they are more broad-spectrum effective. For example, carbapenems select for MRSA, select for vancomycin-resistant enterococci, select for fluoroquinolone-resistant Pseudomonas aeruginosa, and also Staphylomonas multifila, which by itself is inherently resistant to carbapenems. But also cephalosporins select for multi-resistant organisms such as ESBL, Clostridium difficile, and fluoroquinolones in addition also select for MRSA. We do not see this collateral damage with some other substances such as fosfomycin, nitrofurantoin, or pivmecilina. And then we also have a dilemma of empiric therapy because due to the fact that antibiotic resistance is increasing every year, we tend to use more broad-spectrum antibiotics because we fear an increased risk for failure of therapy. Therefore, we are entering a vicious cycle. The higher antibiotic resistance, the higher is the risk of increased failure of the antibiotic empiric therapy, and the higher is the usage of broad-spectrum antibiotics or even combination therapy, which in itself drives antibiotic resistance. And therefore, we need, on the one hand, easy-to-use point-of-care tools. And I'll just give you a couple examples in the next couple of slides. One of it is to have an easy tool to diagnose benign infections such as acute uncomplicated cystitis. And this is just an example. The acute cystitis symptom score is a very simple score to use, patient-administered score, a tool where you can tick the questions, and if the question score is higher than 6 points, then the accuracy of this questionnaire is higher than 90%, that it predicts uncomplicated bacterial cystitis where antibiotics could be used. Another instrument which we have to continuously evolve and investigate is new rapid diagnostic microbiological diagnostics, even with the aim to have susceptibility testing early available within hours. And there are a variety of possible tools, beginning from dipstick testing, which is an old tool. The accuracy is not as good. We have now flow cytometry available, at least in hospitals, until PCR and other amplification techniques which can give you early susceptibility results, because these would help us in the empiric treatment, not to use the broadest spectrum antibiotics in any case, in every case, just to save those last resort antibiotics only for those patients we needed with very severe infections such as urosepsis. This is an example from a study from our colleagues from Basel in Switzerland, Bryson and others, who looked, for example, at isothermal microcalorimetry, meaning that when the bacteria grow, they exert heat. So they produce heat, and this heat can be taken up and can be measured. And if these bacteria are cultivated in the presence of antibiotics, they either grow if they are resistant to these antibiotics, or they won't grow. If they won't grow, there will be no production of heat. If they grow, there will be production of heat. And here in this in these curves, you see that, for example, this bacterium, E. coli bacterium, can grow in the presence of ciprofloxacin or amoxicillin. Therefore, it is, by definition, resistant to these organisms. And you can see here that in this setting, you can get results within 3 hours. So this would be very helpful. Another strategy is to use niche antibiotics in benign infections such as uncomplicated cystitis, and this is now taken up by guidelines all over the world. American guidelines, European guidelines, the German guidelines. In uncomplicated cystitis, you should not use broad-spectrum antibiotics such as fluoroquinolones or cephalosporins. You can use nitrofurantoin, fosfomycin, or pivmecillinum as antibiotics that have primary their indication as niche antibiotics only in these infections. Another question is, do we need to treat bacteria at all in benign infections? And there we have now a shift of a paradigm in asymptomatic bacteriuria, for example, if you have bacteria present but no symptoms. These bacteria can be present even in the presence of leukocytes in the urine. And one early study has been undertaken in patients having diabetes mellitus, where we always thought that these patients would have a more benefit of antibiotic treatment, but this placebo-controlled study has shown there's no benefit of patients with diabetes in the treatment, in the antibiotic treatment of asymptomatic bacteria. There's no difference with regard to symptomatic episodes. And this has been continued by a group from Italy, the group of Tommaso Cai, who looked at patients with uncomplicated cystitis. Between the symptomatic episodes, these patients have asymptomatic episodes, and in this study, half of the patients within these asymptomatic episodes have been treated with antibiotics, and the other half have not been treated. And you can see here those patients who have been treated, they had a higher rate of symptomatic episodes compared to those groups who have not been treated. So it's not only that there's no benefit of antibiotic treatment, you even cause harm in those patients. And this concept has even been taken further by the group of Björn Wult from Lund in Sweden, who have used bacteria from asymptomatic bacteria episodes and instilled those bacteria into the bladder of patients suffering from recurrent cystitis, and they could show that symptomatic episodes have been decreased by instilling bacteria of asymptomatic bacteria episodes into the bladder of patients suffering from recurrent cystitis. And now we have another strategy which targets the direction in patients suffering from uncomplicated cystitis, not to treat primarily with antibiotics, but to treat with pain medications. And in that study, for example, ibuprofen, a pain medication, has been compared with fosfomycin, an antibiotic, and you can see here in 2/3 of the patients that received ibuprofen, no further antibiotic had to be given. So you can, in certain amount of patients, about 2/3 of the patients, you can treat with pain medication suffering from acute and complicated cystitis. Now, many patients also suffer from recurrent cystitis, and in patients suffering from recurrent cystitis, we recommend no antibiotic treatment in the first instance. We recommend, and this is due to this, or it has been shown in this meta-analysis, we recommend either a immunostimulating agent, OM89, Urivaxom or Urovac, to be taken, or in postmenopausal patients, vaginal estriol to refill up the estrogen level in the vagina, and by this filling up the lactobacilli flora. And it has been shown that by these non-antibiotic strategies, you can prevent recurrences in a significant proportion of patients. Now, coming to the most severe infection we see in urology, urosepsis. In our gpiu study, we have seen that the prevalence of urosepsis has been increased over the last 12 years. It started from around 10% to 25% of patients. Now, 25% of urological patients in the urological ward develop the most severe infections such as urosepsis. And if we look at the antibiotic resistance in those patients, and this is where we need active drugs right in the first hours, because if we do give inappropriate drugs, mortality will increase, and that has been shown. And the antibiotic resistance rates are very high in this specific patient group. This is more than 400 patients which we have in this database, and you see altogether only carbapenems have a low resistance level. Even piperacillin tazobactam has resistance levels of 30% and higher. And therefore, recommendations have been given to combine antibiotic substances to broaden the antibiotic antibacterial spectrum, and we have calculated in this study, and apart from the carbapenems, you see that combination strategies, even if you include a combination of piperacillin tazobactam and gentamicin, you will have resistance rates of 20% or higher in these combination strategies. Again, this is the total spectrum of the worldwide study. You have to have your own resistance level. You can take these data as a guidance, but you should have your own surveillance levels. And therefore, we need also novel antibiotics to treat in these severe infections. And fortunately, there are some novel antibiotics already filed or in the pipeline. For example, ceftolozane tazobactam is a filed antibiotic that is also active against certain ESBL-producing enterobacteria. Another filed antibiotic is the combination of ceftazidime and avibactam. Avibactam is a novel beta-lactamase inhibitor, also active against certain ESBL-forming organisms such as CTXM plasmids, such as TEM1 plasmid, but also Klebsiella pneumonia carbapenemase harboring plasmid. So it is also an antibiotic that can be given in certain carbapenem resistance antibiotics. And then we see several other antibiotics that are in phase 2 or phase 3, and we will have the results of some of these and of the other antibiotics within this year or the next year, and possibly there are some new and novel antibiotic substances coming into the treatment of severe infections. But again, we have to use these novel substances very prudently, because the same situation, the more you give these antibiotics, the higher resistance levels will come. And as a last slide, I will only show you a very important study performed from our Italian colleagues from Tommaso Cai, published in European Urology in 2016. And this was an award-winning paper because he looked at the adherence to the EU guidelines on prophylaxis, on preoperative prophylaxis. And in the years 2008 to 2010, he looked retrospectively at the amount of antibiotics given for antibiotic prophylaxis, and then they performed an intervention and looked at the word that the EAU guidelines were consistently followed, and then they had a 3 years post-intervention period where they prospectively looked at adherence, at administration of different antibiotics, and at resistance. And they could show by adherence to the EAU guidelines, they could decrease the total amount of antibiotics given, especially to aminoglycosides and fluoroquinolones. And very importantly, post-operative infections did not increase. And they could also show that E. coli resistance to aminoglycosides, fluoroquinolones, and piperacillin tazobactam decreased significantly. And this was also cost-effective. So this is the first study to show also, and this is very important, that adherence to guidelines have a significant effect, and therefore it's one of the best studies we have seen in the last years, which shows you that adherence to the EU guidelines can save resistance and cut down costs. So in summary, if we talk about strategies tackling antimicrobial resistance, we have to talk that we have a bundle of strategies. We certainly need new antibiotics. There are some new antibiotic substances either already filed or in the pipeline, and we will await several new antibiotic substances in the coming years. But again, we have to deal with these novel substances very, very carefully. We have to use narrow-spectrum antibiotics, at least in benign infections, because, as I have shown you, narrow-spectrum antibiotics have a lower collateral damage than broad-spectrum antibiotics. We have to do antibiotic surveillance, and the gpiu study is the best study where you can participate in November, and would very much like to ask you all to participate in this gpiu, global prevalence of infections in urology study, because the data acquired by this study are directly transferred back to the guidelines and to the urological community. We also need non-antibiotic strategies, and I've shown you, for example, in complicated cystitis, not necessarily you need right away antibiotics to treat the symptoms. Perhaps pain medication is also doing the same, or can be used, and especially in asymptomatic bacteriuria, there are only very little necessity to treat asymptomatic bacteria. One of the areas where you have to treat asymptomatic bacteriuria is before urological interventions. And infection control is an important issue. I did not go into detail in infection control. And all these strategies is antimicrobial stewardship, and antimicrobial stewardship is an important bundle of strategies to keep our weapons against infections in place. So thank you very much. This is the end of this presentation, and you can now start your questions, and I will ask and answer as many questions as possible. So there's one question coming in. Please explain again the study about ibuprofen versus fosfomycin. So this study is a study that has been undertaken by general practitioners from Germany, and they have compared in 2 arms ibuprofen versus and they have given ibuprofen 3 times per day for the duration of 5 days versus fosfomycin single dose. And in 2/3 of those patients, and these have been the patients with mild and moderate symptoms, the patients did not need additional therapy, additional antibiotic therapy. And therefore, if we now combine that with this, with a scoring system, for example, the acute cystitis symptom score, then you could probably dissect out those patients that might not need antibiotic treatment, could go with a painkiller in the first instance. Of course, side effects of ibuprofen have to be taken into account. For example, some of the side effects are gastric ulcers. There you, of course, cannot use these different these painkillers for treatment of 5 days ibuprofen. Another question coming in: what do you think about targeted prophylaxis of rectal swabbing before prostate biopsy? This is a very good question. I did not go into detail in this area, but we know that over the last 10 years there was a significant increase of infectious complications after transrectal prostate biopsy. We also looked at that in our gpiu study, and we also have seen that in 5% of the patients, these patients developed symptomatic infections, and 3% of the patients even developed febrile infections or severe infections such as urosepsis. Now, the primary risk factor is fluoroquinolone-resistant pathogens in the rectal flora. And it has been shown to some extent, if you do a rectal swabbing and look specifically for these fluoroquinolone-resistant pathogens, and this is being done by selective agars, fluoroquinolone selective agars, then by definition, if you swab the rectal swabs over this agar plate, and the bacteria that are growing by definition are resistant to fluoroquinolones, and therefore those patients cannot receive fluoroquinolone prophylaxis for transrectal prostate biopsy, and therefore these agar plates are further processed to resistance testing, and then these patients received prophylaxis according to resistance testing of the rectal flora, and it has been shown in an open study that this targeted prophylaxis is efficacious. So there is another question coming in. Do you think that mesalenam, nitrofurantoin, or fosfomycin can be used for febrile UTI in men? So far, there's no indication to use these antibiotics also for febrile urinary tract infections in men. These antibiotics can only, and their indication currently is only to treat uncomplicated cystitis in women. So therefore, up to now, there's no indication for these antibiotics to treat febrile urinary tract infections in men. There's another question coming in. To recommend to give a narrow spectrum antibiotic after the cystoscopic procedures. Okay, in our EAU guidelines, we have taken a detailed look at what urological procedures do need antibiotic prophylaxis and what antibiotics and what procedures do not need antibiotic prophylaxis. And cystoscopy normally does not need antibiotic prophylaxis. It's described that those interventions where you breach the urothelial mucosa generally need antibiotic prophylaxis. For example, transurethral resection of the prostate, transurethral resection of the bladder. In those procedures, you need to give antibiotic prophylaxis. But in a cystoscopy and a sterile urine, you do not need to give antibiotic prophylaxis, especially after the procedure. If you want to give antibiotic prophylaxis, first, it's usually a single antibiotic treatment before the procedures. After the procedure, there is no need to give an antibiotic. It's no use. Another question is coming in regarding infections in urological patients. Apart from the increase in resistance rates, there is also a change in microorganisms. Yes, I have alluded to that. The microbiome, if you give systemic antibiotics, the microbiome, so if you want, so the good bacteria which inhabited our body, they're also always negatively affected. And this has to be taken into account in each and every instance when you give systemic antibiotics. Another question, what's your point of view about ertapenem previous to transrectal biopsy? No, don't give more and more broad-spectrum antibiotics for prophylaxis. Please don't do that. Ertapenem as a carbapenem, it will certainly be successful if you give it, at least in the next years, but you select for multi and pan-resistant pathogens, especially if you give carbapenems. These are our last resort antibiotics, and if you waste these antibiotics already for prophylaxis, then you will have serious problems in the coming time, in the coming future. And for example, what would you give in a patient that received ertapenem as a prophylaxis for transrectal prostate biopsy if this patient develops severe infectious complications? You have no antibiotic left to treat this patient. So please don't give carbapenems as an antibiotic prophylaxis. Another question, patients with urosepsis with bacteria sensitive only to injectable antibiotics, how we will continue treatment when the patient became afebrile? This is a question that deals with the problem of de-escalating or when to stop treatment in patients who have severe infections or who have infections in general. So one answer to that is, what is the duration of antibiotic treatment in patients when they have urosepsis or pyelonephritis? And there's no general rule, but most of the patients, according to my experience, can be treated with a course of antibiotics of 7 days or even shorter. There are studies that have looked at pyelonephritis and complicated UTI, and in those patients, even a 5-day treatment was as successful as a longer treatment. So in general, most of the infections can be treated with a 5, maximum 7 days course. However, you have to adapt according to the clinical course of the patient. If the patient is not better, then maybe you have to continue treatment, and maybe you even have to think about changing or switching antibiotic, or the patient has a comorbidity or a more complex and complicating factor, such as a renal abscess, for example, then you have to especially look for it. If the patient is doing better and he was on IV treatment and you have the susceptibility results available, you can certainly de-escalate to a smaller spectrum susceptible antibiotic. Another question, do you think that antibiotic prophylaxis is necessary in prostate arterial embolization in men with non-symptomatic bacteriuria? That's an interesting question, because arterial embolization is certainly still experimental. The data that have been presented, however, have shown that it is, at least in a subset of patients, maybe those who cannot operate it, is a tool to treat benign prostatic hyperplasia. I would think in those patients, if they have asymptomatic bacteriuria, I must say this is only my opinion, there is no evidence that underpins this, but I think in those patients, if they have asymptomatic bacteria, you would not gain anything if you treat this asymptomatic bacteria. But this is my personal meaning. Another question, do you need to treat with normal bloods, urine culture negative, but with the cystitis symptoms? I think the meaning of this question is, if you don't have positive microbiology findings, but the patient has symptoms, do we need to treat? My answer to that would be, you have to look. There are several factors, or there are several possibilities why the patient could have a negative urine culture but still have symptoms and even could have an infection. One would be, for example, if he received on the way to the doctor, if he received any antibiotic, and you know, on the way from one to the other doctor, there are multiple possibilities that a patient could get an antibiotic on the way. So if he has had antibiotics on this way, then it would certainly be one explanation why he would have negative culture findings. So if he would have other reasons to have symptoms, such as a catheter, I would not treat. If he has severe systemic or severe signs, systemic signs of infection, then I would treat the patient even if he would have had a negative urine culture, maybe because he has had antibiotics primarily. Another question, so I think we are coming to our end now of our question and answers. Another question is, do you use a 4 to 6 weeks course of ciprofloxacin to treat epididymitis after invasive procedures like TURP? Now, epididymitis or epididymitis should be treated according to the clinical improvement. And we have shown, Dr. Pilatz from my department has shown that even if there are small abscesses in the epididymis, you can treat it by antibiotics only. Sometimes you need a longer treatment, but usually you don't need a 4 to 6 weeks course. We stop antibiotic treatment according to the clinical improvement of the patient. So if the patient has improved after 1 week, we would stop the treatment. If he has improved after 2 weeks, we would continue treatment until 2 weeks. So it's not necessarily that the patient needs to be treated 4 to 6 weeks. We would adapt to the clinical improvement of the patient. Another question, could you give us absolute indications for antimicrobial prophylaxis previous to urological surgeries? So antimicrobial prophylaxis before urological interventions depends on 2 things. One is the intervention, and the other is the patient. In our guidelines, we have put in a detailed list of interventions that need antimicrobial prophylaxis and other interventions that don't need, in general, antibiotic prophylaxis. Just to give you an example, as earlier mentioned, cystoscopy does not need antibiotic prophylaxis in all patients, whereas transrectal prostate biopsy, for example, would call for an antibiotic prophylaxis in all the patients. All the other procedures are in between these 2 extremes. And then you have the other factor that if the patient has a high morbidity, multimorbidity, perhaps described by the ASA score, then you would more likely to give this patient an antibiotic prophylaxis. If it is a healthy patient, then this patient would less likely need antibiotic prophylaxis. A good example is, for example, diagnostic ureteroscopy. If you only have a diagnostic ureteroscopy, not all patients necessarily need antibiotic prophylaxis. We would do that in a more complex procedure. If you, for example, also treat stones, we would indicate prophylaxis, or in a more multimorbid patient. Then we would, even in a diagnostic ureterorhinoscopy recommend antibiotic prophylaxis. Though there is no general rule, but you have to adapt the antimicrobial prophylaxis according to the needs of the intervention on the one hand and to the needs of the patient on the other hand. So I think there is no further question. I thank you very much for your participation, and it was a pleasure for me to give this webinar, and this webinar will be also available on the EIU website shortly after this presentation, and you can look at this webinar anytime after this evening. So thank you very much and have a nice evening.